Thank you very much, Mr. Chairman. Thank you all for being here. Yesterday in Connecticut, the new rates were announced for the two insurers, Anthem included, who offer on our exchanges. There was a announcement of a 17% increase attributable only to the uncertainty around cost sharing reduction payments, an additional 6 to 8% increase due to the uncertainty around the individual mandate. So you're looking at a 20% increase to Connecticut consumers based only upon the uncertainty that this administration is inserting into the marketplace, commands our attention. I actually wanted to essentially re-ask the question that Senator Alexander asked, because I think it is probably the most important question, especially as we try to sort through how we provide some more regulatory certainty to states. I think what Senator Alexander, I'll just ask it a little different way, and I think what Senator Alexander is saying is that because you have the ability under existing law to change these minimum benefits, we're searching for what the existing standard is, how a state would be guided in doing that today, what would be allowed and what wouldn't be allowed, and whether we need to amend that standard or clarify that standard, because it's already permissible, but there's some uncertainty as to how you would be guided. And so let me maybe ask this question to Dr. Turney, but I'll ask anybody to comment on it. If the standard is simple actuarial value of the overall benefit plan, then theoretically that would allow a state or a plan to get rid of, let's say, mental health benefits and maternity benefits, the things that young people use, so long as they load it up on hospitalization or on cardiac services. I'd be interested as to what the upsides and downsides are of a model in which actuarial value is the simple measure of whether or not you can seek that kind of waiver, whether that's the right way or whether there's some peril to providers and to patients if you can essentially move around benefits at will, so long as in the end the amount of money that you're providing to an average beneficiary remains the same. Does that make sense as a question?
I believe the question makes sense, but I might take it a different direction, I think, than you were heading. And that's, as a physician, I'm here to serve our patients. And when we think about serving our patients across our geography, it's very important that we take care of the whole patient throughout their spectrum of, throughout the continuum of life. So we are committed to our patients and our communities in making sure that patients do get preventive care, that they get appropriate screening health care, that they get taken care of during their acute episode of care as well as for their chronic illnesses. Our focus is to make sure that they do have comprehensive benefits, because we know that if they do, they're more likely to come in at the appropriate time, seek care in the office, not in the emergency room, make sure that if a woman has a breast lump, she comes in to be seen and doesn't wait until her skin is eroding because the tumor has advanced. So I think when we think about it probably more from the provider side, where we understand that the patients need care. If they have coverage, they will seek care. We know that outcomes are better with that care.
You'd be worried then about flexibility that would allow you to get a really robust hospitalization benefit at the expense of any coverage for instance, mental health or addiction?
Yeah, we're worried about it for two reasons. One, if you have, for example, catastrophic plan, we're very worried that, first of all, patients wouldn't come in for other care because all they have is a catastrophic plan. And if they do need to seek care, there's a good chance that they're not going to be able to afford that care. So that's the one issue. And actuarially, yeah, we have to look at balancing the business in making sure that we can run our business. But we want to make sure that people do have the most comprehensive benefits they can get. And we're not going to, I mean, can you carve out benefits? Absolutely. And can people choose to do that? Certainly. Not all of our patients are insured by Security Health Plan. So we do have to deal with a number of different options. But our philosophy is to take care of the whole patient.
I will stipulate that it's hard to figure out what the measurement would be other than actuarial value. But therein lies the problem. If it is, then you potentially provide some significant gaps, and you get rid of the certainty of product that was part of the reason that we put it in, so that when you bought insurance, you knew what it is. But I think this is a true conundrum. If it's not actuarial value, then it's kind of hard to figure out what the substitute standard is. Thank you, Mr. Chairman.